Dr. Hung and I are going to be talking a little bit about really trying to tailor epilepsy care to CDD. So just to start with some disclosures, I don't have any formal disclosures, but I do like to make sure that people know that I was a site PI for the Marigold trial, which at the time was Marinus for ganaxolone, and that I have worked on some other trials, including trofinetide and gene therapy trials for Rett syndrome, and I do receive some funding, thank you, from IRSF as well as the NIH. Show of hands, how many people have heard of vagus nerve stimulator in this room? Okay. Just as all good. How about corpus callosotomy and DBS and RNS? Okay. I thought most of you would be familiar with these terms, but just like to kind of get a feel of the audience. So in talking about VNS, where we're at with VNS is no different than the talk I gave 2 years ago. We know that there has been a case series published that showed that greater than 50%, there was a greater than 50% responder rate in terms of getting a reduction in total number of seizures. And some families have reported improved mood and behavior. And one of the hopes with the VNS is that it may allow reduction in number of medications over time. But when we start talking about surgeries, one of the big things that obviously comes up is there's an upfront risk. It is a surgery, albeit the VNS is the least invasive of the surgical options that we discuss. It's just skin incisions. We're not going into the brain, but it still carries that risk of an incision anesthesia. Technically, it's currently approved only over age 4 also, by the way. At our institution at WashU, they kind of look at weight. And then, of course, we rarely get an insurance issue at this point with VNS, but they usually like to see well over 20 pounds before we talk about implanting. The settings can be adjusted over time, but it can be hard to know when have we actually maximized the VNS, when do we feel confident that we've seen the full benefits, because some of the best data out there says it may take over 18 months to really see the full benefit, but we can't just stop making other management decisions for 18 months most of the time. We do have to be aware of a risk of worsening obstructive sleep apnea, so I recommend getting a polysomnogram, a sleep study before implantation, and monitoring for evidence of symptoms on intermittently to make sure we're not hearing about snoring, pauses in breathing, in sleep. As a device, it can malfunction, but even if it's working at its best, they do not last forever, so you do have to plan for a surgery to replace the stimulator every 8 to 10 years, we think, with the newest models. One of the things I've been thinking a little bit more about now with VNS is potential limitations on imaging. So with a VNS in place, because magnet is part of how it works, the VNS does have to be turned off, but you can get an MRI of the brain. However, it does limit chest and some spine imaging, and that may come into play with gene therapy trials. I don't know any more specifics. I just think that's an important point to be discussing if you're thinking about this decision moving forward. So I'm just going to add that little piece, because nothing ever gets simpler, does it? So then I'm going to move on to probably what I think comes off as the most intimidating surgery that we ever talk about, which is corpus callosotomy. It is actually one of the oldest epilepsy surgeries, and I think most of you said you were familiar, and I have an image on my next slide that sort of reviews, but you have this large bundle of nerves that communicate between the two sides of the brain, and you essentially make an incision through that to decrease the speed of communication between the two sides of the brain. And the hope is that this will decrease the intensity of the seizures. The goal is not seizure freedom, though occasionally we get very long seizure holidays. To date, the longest I've had is 5 years, and no, it was not in a CDD patient, though I would have loved it. And what we most hope for and usually do see is an improvement in intensity or frequency of the seizures. It's most effective for individuals who are ambulatory or who are walking and are falling with their seizures, and we can significantly decrease injuries with that. We have some different retrospective studies that have shown anywhere from approximately a 2/3 response rate. At the same time, there are some very significant upfront risks because this is a surgery that we are cutting into the brain. In the past, it always had to be done as an open craniotomy, where we were truly opening the skull and the covering of the skull to get to the corpus callosum and make the incision. But we do now have laser option, which makes it much less invasive and the recovery better, but it is still, ultimately, there is still an incision being made within the brain, which would carry risks. So one of the things that we were able to accomplish a little bit with the ICCRN, the U01 study, was to see what information we specifically had within those individuals who participated in that study, how many of them had had a corpus callosum. And I have a picture here of one of our research coordinators who is leaving us this summer to head to medical school, Sydney Panagos. And we were able to find 5 individuals in that study, and we were even able to, some of them we have longitudinal data on their severity scale. So in that group, we found that there were 3 boys and 2 girls who have had the surgery, who at the time of surgery were anywhere from ages 2 to 11 and are now anywhere from ages 7 to 25. I don't think I'll be giving anything away if I tell you guys that the 25-year-old is my patient. We know that one of them was a laser procedure, the other 4 were open. Things that I think were quite useful to be able to clarify was that there were no loss of developmental milestones with this surgery. I think that's one of the biggest fears you might have after the upfront risks of the surgery. And essentially, whatever developmental severity category an individual was in going into the surgery, that remained stable. So if the individual was able to walk, and actually in one case we had somebody who had not yet learned to walk, but was showing signs of progressing that way, they still continued that progress. So ambulation was maintained, level of speech was maintained, and the number of anti-seizure medications was able to be decreased. We aren't really able to comment on how much it helped seizure control. I can tell you that none of those patients are seizure-free, at least based on parental report in the chart. There was a perceived benefit of improvement in seizures. Obviously, in an ideal setting, we would have very precise seizure counts before, after, and at very set time points, but this study didn't allow for that. So I think it still remains a very interesting option because while it does carry some upfront risk, it is one of those things where you make this big decision, but afterwards you're kind of done. Either you did it or you didn't. But of course it cannot be undone. Deep brain stimulation is something that has been increasingly discussed within the DEE and Lennox-Gastaut syndrome world. In this case, unlike the vagal nerve stimulator where the device is implanted under the skin and the wire is wrapped around the nerve in the neck called the vagus nerve, a deep brain stimulator, the stimulator is implanted here again, traditionally, and then the wires actually go into a deep part of the brain called the thalamus. To make things more complicated, there's another device called an RNS where traditionally the stimulator was implanted in the skull and the wires went to an area of the surface of the brain, but there are now many situations in which the stimulator device is being implanted within the skull, but the targets being used are the same as a deep brain stimulator, so the thalamus. And there are also options of recording versus recording and stimulating. In any case, there is no published or official data specific to CDD, but there has been an increasing amount of data about it for Lennox-Gastaut syndrome, and it is showing significant evidence of benefit, not seizure freedom, but again, decrease in seizure frequency and severity. The biggest issues, of course, are this is an implanted device, and not only is it an implanted device, but it's an implanted device into the brain. And so as you can imagine, if you get an infection in wires in the brain, that is a bigger deal than an infection in wires in the skin. If you have bleeding, it's in the brain as opposed to the skin. So there are higher risks to a DBS than a VNS. It can be turned off, as can a VNS, and a DBS can be removed. And in some senses, I was actually discussing this with one of my colleagues yesterday, in some senses, removing it is actually potentially easier than a VNS because with the VNS, the wire is somewhat wrapped around that nerve. But any of those things are surgeries. So it is a bigger decision than any medication decision that you would make. And there will also be some discussion, I think, as we consider gene therapy delivery systems about whether a DBS interferes in any way with that. One other point that I was reminded to emphasize yesterday is you can do a corpus callosotomy before a DBS. Let me make sure I don't say this backwards. It's been a long day already. You can do a corpus callosotomy before a DBS, but not after. So hopefully everybody's following me. So before I get into medications that are a little bit more on the horizon, a little bit newer, just sort of a summary of where we are, and what Dr. Hong has already alluded to is there is no single best treatment. None of these approaches that we're offering you are cures because we're not getting to the essential, the underlying etiology. There is not one right treatment. It is a constant consideration of what are your goals, what are your biggest challenges at any one time, what side effects are you most struggling with, what other symptoms are you dealing with that are the biggest problem, and really working closely with your most trusted medical team. Though it is never a bad thing to get a second, third, fifth opinion until you feel comfortable with where you're at. And I know that I am always happy for families to ask me more questions or to seek advice elsewhere because I can always learn more. So what is sort of newer or on the horizon? So I don't know if we should still be thinking of ganaxolone as new, but I would say I am still thinking of it as new. Not because it was just FDA approved, but it's still relatively new in my general experience. And so I'm still trying to figure out when is the best time to bring it in, what seizure types is it potentially more effective for, and unofficially I really am wondering about using it in the under age 2 group. One of the things that, we all have seen the data from the Marigold trial. It definitely did show seizure reduction, but we often see that with new medications. Is that a sustained benefit? Is it a more sustained benefit than with other medications? Do we have better benefit if it's introduced earlier? Because of course, any one time we introduce a new medicine, you're on other medications at the same time. Personally, I try to avoid having ganaxolone on board with other GABAergic agents because the sedation, I find, tends to be more significant in those cases. So for instance, vigabatrin, clobazam, I find those to be particularly sedating combinations with ganaxolone. And sometimes one of the biggest things you have to do to test the efficacy of that new medicine is to decrease one of the other medicines. Fenfluramine, or Fintepla as its brand name, is a medication that I actually have prescribed more outside of a trial because I do also follow a cohort of patients with Dravet syndrome in my general clinic. It is very clear that fenfluramine has been very effective for generalized tonic-clonic seizures in Dravet syndrome. That data is very conclusive. And we do have preliminary evidence that Fintepla has been beneficial for individuals with CDD in decreasing their what we call countable motor seizures, their tonic seizures. But because it hasn't been widely used in large numbers, we're still trying to get a feel for it. It is important to know that it is a different mechanism of action. It is a serotonergic agent, which is relatively unique compared to a lot of the other seizure medications we use. So there really is no current equivalent, though there is one that was mentioned this morning in the potential trials. We do require regular echocardiograms because of the data that we had from experience with fen-phen, but fortunately the cardiac data has been very reassuring in pediatric epilepsy young children so far. And we also do have to watch out for appetite suppression. Another medication that we have been talking about for a bit now also is soticlestat. That is only available, there was a research study some of you may have been aware of that works by a unique mechanism. Unfortunately, currently that trial is sort of stuck. Those who were able to get into it have been able to maintain an open label, but we tried to get some more updates before this talk, but I don't unfortunately have any more updates on where that stands. But there was some preliminary evidence that was hopeful, and we just don't have any more information at this time about where that, what might happen with that in the future. And then finally, I'm going to mention one other medication that is FDA approved, but not for anybody under the age of 18, and that is cenobamate, or its brand name Xcopri. And we do have some evidence at this point for its use in Lennox-Gastaut syndrome. So it is a FDA-approved medication for adults with focal seizures. It has sort of a unique mechanism because it has some sodium current activity, but also some GABAergic activity. And there's just some emerging evidence that a lot of my colleagues I know what I'm talking about, that we're seeing that it seems to be a stronger and more effective medicine than our average medication. That being said, we don't have clear-cut data to support that. It's not an organized study. And then there are also some practical considerations. So it has to be slowly up-titrated. Much like the medication lamotrigine, there is evidence that if you titrate onto it too quickly, you could get Stevens-Johnson syndrome, which is a serious rash. So it has to be titrated very slowly. It also can cause significant sedation. And so you have to be aware of other medications that it's on for, or that your child is on, for two reasons. One is the potential combination of sedating effects, but then there is also significant pharmacologic interaction. So it really will elevate clobazam levels in particular, but there are some other complex pharmacologic interactions. So that is something to always be aware of. Sometimes when you're seeing a side effect with adjusting a medicine, it could be because of its effect on another medication's level. Many of you have probably tried Epidiolex, the FDA-approved formulation of CBD. That raises clobazam levels. This is way more. And I learned that the hard way the first time I tried it. Elia's laughing here in the front and pointing, yeah. Interactions are a big part of management when you're dealing with what we call polypharmacy, more than one medication. So this was what I'd call a sprint marathon through epilepsy management. Tried to sort of emphasize some of the more specific things to CDD and give you a sense of the landscape of treatment right now. So sort of our key takeaways. CDD epilepsy is different. That early onset, maybe you see some benefit, but then suddenly you're either dealing with a new phase of the epilepsy, or that benefit seems to have worn off and you're back where you started. We do not have cures yet, but we are really hopeful because there's so much effort and so many exciting things on the horizon. And you have a lot of options coming. But for right now, constantly having those good discussions to make sure that it's aligning with your overall goals of care and optimizing quality of life are really where we are.
My name is William Hong. I am neurologist and epileptologist at Boston Children's Hospital. I started working alongside Dr. Hedda Olson in 2021. So today's roadmap, we are going to talk a little bit about what makes CDD epilepsy unique. What are some medications options? What are like non-medication options, non-pharmacological options? And what's in the horizon, what's in the future, what's more active things about treatment related to seizures and epilepsy. So we'll start with what makes CDD epilepsy different. Let me give a quick background about CDKL5 Deficiency disorder. It is a developmental epileptic encephalopathy that suggests that there is an underlying genetic cause that contributes to delays in development, but also the seizure can also be a negative contributing factor to your overall development. And global development delay is the most common symptoms and most burdensome symptoms, but epilepsy comes next. What's a little bit unique about epilepsy in CDD, CDKL5 deficiency disorder, is early onset epilepsy that is drug resistant. That's the hallmark. So the onset is in the early infancy. It usually starts with like what we call a focal seizures, where perhaps one part of the body go into like abnormal posturing, stiffening, shaking, and then many of them actually will develop infantile spasms. That's probably the most common type of epilepsy, seizure type in CDD epilepsy. And then it also actually can persist as an epileptic spasms, meaning you are out of the infantile stage, but you continue to have spasms. And then as the epilepsy progresses, the simplified version is that they go into 3 stages. So once you go into stage 2, you can have different types of seizures, including tonic, tonic-clonic, and what's perhaps a little bit more unique about CDKL5 seizures, and they can have sequential seizures where you have a different types of seizures that kind of occurs back to back. They can have like hypermotor seizure. You're kind of making some large irregular like movements of your extremities, followed by tonic seizures and followed by spasms. And then they can, these seizures can unfortunately can be very resistant to medications. I want to say that seizures do not like define your child, but if you can get a better handle on the seizure control, then it can open doors to like everything else, meaning with improved quality of life, you may be able to better participate in school, therapies, have meaningful interactions, communications. So it is a very important part of overall care in children with a CDKL5 deficiency disorder. But it is a very challenging disorder in terms of seizure control. Many children will have multiple seizures per day. About 2/3 of the children CDKL5 deficiency disorder will have multiple seizures per day. They may get a little bit worse as you go into like a toddler, early elementary age, and then maybe get a little bit better as you go into like adolescence. But a majority of them will have multiple seizures per day. So if your child is experiencing multiple seizures per day, you're not alone in that category. And they're also resistant to anti-seizure medication. So about 2/3 of children with a CDD will be on 2 medications or more at a point of time. So the early infant onset, the sequential seizures, and the drug-resistant component makes it different from something like that's related like Rett syndrome disorder, which is usually like later onset, relatively compared to CDD, easier to control. So what are some of the options? What medications can we use? What are something we can do to treat these seizures? So before we talk about medication, it's important to talk about the goals. So the overarching goal is to optimize alertness, development, support participation in meaningful daily activities, ultimately to improve your overall quality of life. So we know that seizures that are prolonged, seizures that occurs multiple times in a row, they can become sleepy after, and that can just take out hours in your day that you could have used to go to school, participate in therapies, or make eye contact with the parents. But so it's important to recognize that seizures needs to be controlled, but at the same time, when you use medications to control seizures, they don't come in side effect free. A lot of our children are very sensitive to medication side effects. So despite us going like low and slow approach, they can have side effects. They can have decrease like executive function, decrease in tone, become more sleepy. So ultimately, we have to find like a good balance of seizure control and medication side effect. So what is like a good goal? Like we should work on reducing the like most dangerous seizures. Earlier, like we talked about like SUDEP, so like tonic-clonic seizure where your whole body is shaking, that those happen at nighttime. Those are a relative risk factor for increased risk of SUDEP. So those should probably treated more so than other like short, brief lasting, like scattered throughout the day if they don't cause like prolonged post-ictal period, meaning like if you kind of bounce back from the seizures relatively quickly, then perhaps adding a medication may do more harm than having the seizures. So it's important to kind of think about like what medication is my child on, what role does each medication have. Not to say we should take off all the medication all at once, because everything we do, we have to do slowly and gradually, but it is always something that we should think about as we talk about like treatment of epilepsy, especially when it comes to medications. Over the past 100 plus years, there has been about 50 medications that are targeted for seizure control. And despite these very quick advancement in seizure medications over the past few decades, we still have difficulty controlling some of the seizures. I put the slide here just to say like the number of medications we have available, and then how each medication may have like unique properties, how it can work in terms of mechanism of action and targeting to reduce the seizures in the connection and network in the brain, in the central nervous system and the brain cells. So different medications work different way. It can help with the abnormally high signal between neurons to neurons. It can help like also controlling how the signals transmit within the neurons, and then how the other neurons can receive those signals. And this becomes important when we think about like overall balance of using anti-seizure medication. When you're on multiple medication, we think about using perhaps different mechanism of action, kind of spaced out, so that we're not targeting just one mechanism of action that may cause some potentiation in one particular side effect. So what are the evidence that we have for CDD epilepsy in terms of anti-seizure medication? Well, ganaxolone, it was approved specifically for CDD in 2022. Fenfluramine trial, it's not FDA approved yet, but it showed positive results in CDD epilepsy. None of those like specifically target the underlying pathophysiology of CDKL5 deficiency disorder, but at least it has shown that it can be helpful for seizure control. Outside of that, like many anti-seizure medications are not studied in young children, let alone like CDD. So when you don't have a lot of evidence out there, you kind of have to think about what is like the closest thing you can think of, and then kind of extrapolate the data and then apply to your current situation. So one common syndrome that we may use to extrapolate the data is Lennox-Gastaut syndrome. This a syndrome, meaning it's not a one particular condition, but it's a group of symptoms that can give you something similar to like CDD, where you have like developmental delay, multiple seizures, refractory seizures. So we may use some of the data, that medication that we know it helps in Lennox-Gastaut syndrome, and also rely on expert opinions, small case series to have a discussion about what medication that has helped for certain children, could that also help for my child. So those are some of the things that we think about. But ultimately, there's no like one treatment plan that works for everyone. Having the discussion with your doctor and us as a physician with the family can be very helpful. It is, I usually try to say, because this topic kind of came up in the earlier session, I think it's important to like talk about like what medications, so give families options, what are the pros and cons of each medication that I'm thinking, and then maybe like cautiously make a suggestion about, I think this medication could probably use as the next option, and then we can always make decision collaboratively with the family. In general, we like to use what we call like a broad spectrum medication. That means we use medications that are helpful, potentially covering different types of seizures. They often have different mechanism of actions come into the play. The list here is not in any particular order. And then when you do, when you're selecting medications for epileptic spasms or infantile spasm, we still rely on the data that we know about like infantile spasms treatment in general. We do know that infantile and epileptic spasm CDD can be more difficult to control, and they can have a higher recurrence rate, but our first line of therapy is still steroid, hormonal therapy, and vigabatrin. And then we also think about ketogenic diet as a second line treatment plan also that can potentially give you a little bit of more sustained benefit than steroid or vigabatrin. So overall, setting up a good honest expectation, building a trust and rapport with your physicians and with your family to provide comprehensive discussion in order to make the best outcome. I'll do quick summary of the rescue medication. So there are different types of rescue medication. These are not your daily medications, but almost like an emergency medication to use at home. Typically, we would suggest like rectal gel or a nasal spray in the form of that is a benzodiazepine to be used if there's like a convulsive full body shaking tonic-clonic seizure that are longer than 5 minutes. Because spasms clusters are so common in CDD, we also have to be careful about not using these rescue medications for cluster of spasms that are longer than 5 minutes. They are different types of seizure. They have different response. So we try to avoid using these sedating benzodiazepine class medications for cluster of spasms. So again, it's important to kind of talk to your doctor, talk to your families about what are your seizure types, how can we like make a best plan, how do you recognize what seizures or what type, and then come up with the best plan that's individualized for your child, and come up with a seizure action plan and kind of distribute it to all your caregivers, all of it, child's caregivers and school personnel as well. And what about non-pharmacological, non-medication option? I'll talk a little bit about ketogenic diet. There was a great session just an hour ago. But ketogenic diet is a high-fat, low-carb diet where you kind of trick the body into like a starvation mode, but you're not actually starving the child. You are giving fat as like a major source of nutrient, and that can help your body build ketones, which has multiple mechanism actions, not just by ketones, but just being on the starvation ketosis state that can be helpful in terms of seizure control. So overall, in general, with a ketogenic diet, when you do the diet on child who has medically drug-resistant epilepsy, the expectation is that you may have a 50% decrease in your overall seizure burden. That may happen about 50% of the children. We don't have like a great large data on CDD, but as far as we can collect the data on that, a seizure reduction seems to be more or less similar to general refractory epilepsy. And then if the ketogenic diet is successful, then we can certainly think about like, can we actually reduce some of the medication that's causing the most side effect and perhaps not the most beneficial. But even if you don't change your medication, some families report that, yeah, my child is more alert, they're more aware, their mood is better, their sleep is better. So we do see cases where you see some secondary benefit other than the seizures, even though the primary goal of ketogenic diet is for seizure control. it is not a diet that you would start by yourself. It is guided very strictly by your medical team, including your neurologist and your dietitian. There's a risk of like acid-base imbalance, high cholesterol, deficiency in vitamin and minerals, just by the nature of the low-carb diet. And then certainly semi-long-term and long-term side effect, risk of kidney stones, bone health, overall growth, those all need to be very closely monitored. And I put the hypercalcemia in there. That means your calcium level in blood is high. Interestingly, with a ketogenic diet, you are actually deficient in your calcium intake just by the nature of the diet. So many kids actually will start like a calcium supplement. But we had some cases where the calcium level becomes too high, and we don't think it's not necessarily related to like calcium supplement, but perhaps relate to like a bone health to be discovered. But we do know that it is something that can happen, and when it does happen, we do have to collaborate very closely with other colleagues in nephrology, kidney doctors, and endocrinology and hormone doctors who can manage both kidney fluid status and your bone health as well. And then in terms of a ketogenic diet, last thing I want to say here is that there are some thoughts on how if you start the ketogenic diet early, perhaps could that help you with like long-term seizure benefit, long-term development. So Dr. Olson from our Boston Children's CDKL5 Center of Excellence has an ongoing trial to look into ketogenic diet for prevention of epileptic spasms in those who have genetically diagnosed epilepsy.
Well, thanks for this information. I'm going to ask a question that is probably confusing. It makes sense in my brain, so I'm going to try and communicate something. I'm wondering, between all the medications that are out there, you know, we say this medication hits this receptor, this medication hits that receptor, you know, and so on. How do we know in our children? So my daughter's on 3. I find myself paralyzed at the moment. I want to make a change. She's stable, but I feel like quality of life is not where it should be, so she's sedated. Is there a way, or is science to the place where you can look at the particular child and know, like maybe the panel of her metabolic system or whatever she's got going with the markers? I don't even know what those markers are. I'm not a scientist. What medications then would work better with this particular child? Or are there ways to study?
Are there ways to predict what might be the best choice for your individual child?
Yes, and look at the medications that she's on. So if she's on these 3, are 2 of them hitting the same receptors? Should we vary it? You know, those kinds of questions that I need to know how to ask. To I don't know. It's all.
You're making perfect sense to me. So, so what I would say, you know, as your child's neurologist should sort of have in their head, oh, I think that when we added this or when we went up there, that's when we got the sedation. Like looking at the history, when did we get what change? Or looking at these medications, what is the most likely, say, to be contributing to the sedation? You can also check medication levels for most of our medications and get some useful information from that. One thing that I think a lot of people wonder about is pharmacogenomics, which is where you can actually do personalized testing to look at your cytochrome P450 system. There's some misunderstanding out there, though that does not actually tell you how well any one medication is going to work, but it will tell you whether you're more likely to be a rapid metabolizer of some medications or a slow metabolizer. So that would say, oh, this is a person who a very low dose will get them to an effective level versus this person would need an extra high dose to get to an effective level. But that only tells you the medication level in the system, not whether it's going to work to control the seizures. So there isn't, what we need is that Star Trek, someday you walk through a scanner and it says this is your treatment and that's what's going to work perfectly for you. We don't have that, but careful history, and your neurologist knows what the mechanism of action of the different medications is and could think through that, but it does require just sort of carefully looking at notes over time and thinking through where things are at. Is there anything else?
Yeah, I'll just add that I think many of us can get a little nervous, anxious when we're thinking about taking medication off. But as we kind of surveyed briefly earlier today, sometimes seizures gets better when you take off medications, and they can also come with improved sedation. Coming out of a sedation, there's also some thought if you're too sedated and you are constantly going in and out of awake and sleep phase, then that could be also a risk factor for having more seizures, because that can sometimes happen when you're kind of in and out of that awake and drowsy state. So I think ultimately, yes, I agree that history is very important, but sometimes I think if you feel like the quality of life is not optimized, you just sometimes just need to take a leap of faith and then try and be bold and take medication off. And you also have to be careful when you take medication off. Sometimes you see a transient worsening seizures, and I say transient because sometimes you see worsening seizures and it just kind of stabilizes, kind of gets better. But again, it's that nervousness and anxiety. Oh, seizures are getting worse. We're gonna put it right back. So that has to be really planned, individualized, and talk with your neurologist to come up with a plan. So those are the points that I wanted to add.
I would like to add that the limitation of the pharmacogenomic studies is that not all drugs are included there. So you get lamictal, topiramate, the benzodiazepine, some of them.
I think some of it depends on which panel, but yeah, what Dr. Elia is saying is the pharmacogenomics panels are not all fully comprehensive. They're going to vary in the information. Where did the mic?
Oh, okay. Hello, I'm from France. I'm a mother of Rilan. He's 2 years old and has CDKL5. He has been on 3-1 ketogenic diet for more than a year. He still continues to have seizures, and we don't know if the diet is helping or not. I'm worried that if we stop the ketogenic diet, his seizures could become worse. So how can we determine whether the diet is truly benefit him?
So of course, I should have said, of course we can't officially give any medical advice about any one child here, but the general question of how do you know about something like ketogenic diet, which is more, and I think it's similar with VNS, how much benefit it's providing at any one time, because your child is growing and developing and changing. I often say in my clinic, we need to clone your child and, do one thing to one of the clones and not to the other to be 100% confident that whatever we're doing is helping. And so I think it becomes a discussion of, are there negative effects from the ketogenic diet? Is it causing problems with quality of life? That make us think it's not a safe thing to continue. Our practice at our clinic, and I'll be curious to hear what Dr. Hong's is that we try not to do more than 3 to 4 years of ketogenic diet, but it becomes a risk-benefit discussion at each visit, whether it seems worthwhile to continue. Ultimately, we will attempt a wean at some point, and if we feel like seizures are worsening, we will say, okay, maybe we shouldn't wean, or we're going to bring in a different treatment. What else would you add?
I would add, I think a comprehensive review of medication history, ketogenic diet course, what does the level show, what does the ketone show, what are the side effect profile, that all needs to be incorporated into making the decision. We generally tend to say, most responders to ketogenic diet, you may start to see benefit within first couple of weeks. I said most, but I should say I should downgrade to many. And then there are, if you are on like a classic ketogenic diet, and again, many who benefit from the diet will start to see response at like 3 months. If you're on non-classic, like modified Atkins, low glycemic, then probably give it a little bit more time. And then also depends on how good of a ketosis are you making. Are you eating like mild? Are you G2? And then ultimately, also, as I alluded before, considering the balance between benefits and side effect, we don't know like exactly long-term side effects of ketogenic diet. So we also understand that it can be quite burdensome to the family in certain situations. So considering a weaning off 2 years plus mark is considered, even if you or child may have benefit from the ketogenic diet. And then last point I want to make is similar to how I commented before. If you're gonna wean something, you may see a little bit of transient worsening of seizures, and then you can, again, it will be a discussion with your neurologist. Do you go back to the higher ratio? Do you like pause, or do you wean off more slowly? So a lot of things to think about depending on the individual cases.
We're just when we looked at our keto experience in CDKL5 specifically, while we do see some benefit like the limitations and a decent number of the individuals who tried it, the effect can wane over time. A lot of those individuals came off of keto diet without significant worsening, so if you don't foresee benefit, there's not necessarily a reason not to do it unless there's an individualized reason to it. You can go slowly with your dietitian process. So it doesn't have to be forever, and the other situation that we've seen rarely is a keto done well in the ketogenic diet. It's unclear that necessarily the whole factor of the MSC even caregivers, etc.
And the other thing to consider is if your child is doing relatively well with the diet, and you can consider to change it to a modified Atkins diet, and that's a transition that often can be very success. And
So, yeah.
It's a chance to get a little bit more.
I'm not sure if our microphone is working, but yeah, she was saying you could consider switching to a modified Atkins or a modified ketogenic diet as well as an option. We didn't really talk about modified Atkins or low glycemic index, just we were trying to summarize a lot in this talk. I think maybe we have time for one more comment, because I think we're supposed to let the next speaker start in 4 minutes. So we're happy to find anybody who would like to talk with us at various breaks with other questions. Okay, we'll take one more back there.
I was curious, some people in this room might be familiar with this. Anytime our daughter's been under anesthesia, her seizures have improved, we've asked her neurologist briefly about it. She didn't really want to talk too much about it, but I was curious if there was any kind of research or trials or anything looking into maybe like a maintenance type of thing for anesthesia. I know it's not like something we want to do all the time for our children, but it's very interesting in what is helping it, why it's helping the seizures, and I mean, she's a completely different child sometimes after her surgery. She's happy. You know, her behavior's even improved after surgery. So usually you think she would be, you know, she's in the hospital after surgery, she would be the opposite, but she's actually improved. So I was just curious if there's anything going on, or do we know what's going on with that?
So actually, there's a lot that we could say about that. So first of all, some of the medications that we use, for instance, when people present in prolonged continuous seizures, are also medicines that we use for sedation. Medications like propofol, medications that are benzodiazepine drips like Versed drips. And so is it because the individual got a bolus of a stronger medication? Because you can stop all seizures if you basically induce a coma, but that's not really conducive to a good quality of life, in my opinion. So in all seriousness, I have definitely seen that many times with not just patients with CDKL5, but others of my epilepsy patients where they seem to get a seizure holiday. Have you seen that as well? Yeah. And I think the leading theory is that it is that higher dose, even though it's for a short period of time, of a more potent medicine that sort of calms the brain down, if you will. One medication, ketamine, is being used in intermittent IV doses for some psychiatric indications and things like that, but perampanel has some overlap in mechanism, so I've wondered a little bit about that, but I'm getting to a point of high-level speculation, I think, in terms of what's actually like clinically available, but I think that's probably the biggest driver is that period of higher anesthesia.
Yeah, I don't have much else to add. If you look at the literature on like anesthesia just in general, it can be pro-convulsive, it could be anti-convulsive, so you kind of have to be careful about like using it as needed and judiciously. But if it helps your child and surgery was needed, I'll take it.
Do they ever consider it for rescue med? Because like the rescue meds listed don't seem to help my child in a rescue situation in the past when she was really little.
So it sort of depends on the circumstance that you're talking about. Like we have some patients who will get a dose of IV ketamine as part of a status protocol, like they're in continuous convulsive seizures. But for like cluster seizures, I'm not sure anybody would consider that risk to benefit. But yeah, so it sort of depends on the situation, but not standardly.
I have a final question regarding oxcarbazepine. What is your experience of and how long can it really work? Because, for example, my daughter is almost 10 years with oxcarbazepine, and we are wondering which one is really working.
So are you saying carbamazepine? Oxcarbazepine?
Yeah.
Well, honestly, that's one I tend not to use as much because it's considered sort of a more targeted to focal seizure medication. But I think this speaks to the fact that every child is different, and so so getting into specifics of one individual. But in general, oxcarbazepine is not one that I commonly prescribe because it's not what I would consider a broad spectrum medication.
I would echo that. Yeah, there's also some very small evidence, but something to support. If you use oxcarbazepine early, can that be like a trigger to like onset of spasms? I don't think the evidence is big enough to like fully avoid oxcarbazepine. But at the same time, if there are other options, why use that will be something that I would throw into the question. If there is a potential risk of doing these spasms, for example. But yeah, I think it's important to like. It's hard for us to answer the question directly without understanding the entire picture.
Well, the treatment is still individualized.
Yeah, every child is their own selves. They're not just one gene. So that's, I think, the most important takeaway. All right, well, with that, I think we'll stop because the next speaker needs to get up here. But it was a pleasure to be able to speak here, and thank you for giving us this opportunity.